Hi everyone, my name is Craig Ronco and I am here to present my DNP scholarly project on emotional intelligence and its effect on burnout in the post-acute long-term care. First, I'd like to thank the committee members that helped me through and succeeding in this project, my DNP chair, Terrence and Heinrich, faculty chair, Dr. Stegman, and my third-party reader, Dr. Kia Mellon. And then obviously all of the faculty and staff in the Catherine McCauley School of Nursing that helped support me through the fulfillment of my requirements regarding this project. So thank you. First, the significance and background. Burnout in healthcare, we know, is a crisis. It was a significant issue prior to the pandemic, and now it's even escalated over the past 2 years to really exponential heights with significant consequences across the healthcare system and to the individuals that suffer from it and the patients that they care for. Emotional intelligence has been really popularized since the 90s, originally conceptualized in the 80s, and even prior to that, with multiple levels of intelligence studies through psychology work, and it's been a shown and proven benefit in the aspect and care of burnout. And so, really, the aim of this study was to study healthcare professionals working in the post acute long term care setting and the effects of emotional intelligence training on their burnout. So, in the literature review, really, again, has been an ongoing issue prior to the pandemic. Looking back, pre-pandemic, burnout prevalence was as high as 40 to 50% in physicians, 30 to 40% in nurses, depending on the healthcare sector, and really as high as 75% in physician residencies. And then through the pandemic and post-pandemic, there's been surveys and compilations of data collected that have noted in the post-acute long-term care setting as high as 80% of healthcare workers in that setting have experienced some form of burnout. So it truly is an issue. And then the risk factors associated with burnout, or contributing factors, they've been across the board from job-related stressors, high workload, low staffing levels, long shifts, loss of control of autonomy. It's also been looked at and linked and evaluated from a gender perspective, hours work, social environments, mental health, workload, poor leadership. So really, there's a multitude of factors that influence burnout. Adverse effects are significant and vast. And really, one of the largest aspects of and adverse effects of burnout in terms of measuring is emotional exhaustion. And that's been found in 30 to 75% of studies done on burnout to be one of the largest contributing factors of burnout, because really it looks at the most common popularized approach to burnout focuses on three main aspects: emotional exhaustion, depersonalization, and then personal lack of accomplishment. And really, that emotional exhaustion seems to be the largest impacting. And then there's other things such as somatic complaints, quality, safety errors, suicide, turnover, really some really adverse effects related to burnout that affect everyone. And then emotional intelligence and burnout, that's really been linked to lower burnout scores. It's been linked to improvements of feelings of self. It's improvement in leadership that has decreased burnout. And really, even emotional intelligence, higher levels have been linked to improved quality of care. When you look at the data as a whole, in terms of strengths, weaknesses, gaps, and limitations, the strengths is that there is a robust evidence of and studies done on the benefits of emotional intelligence and its effects on burnout. So that certainly is there, and it's across various aspects of healthcare, and it's across the globe. This multi-international research has been done on the improvements. In terms of weaknesses, the sample size and study design are really more observational, lower sample sizes. It lacks controlled randomized studies. it's regressional too, so it's lacking from that standpoint. And the gaps is there's really not a whole bunch of data done on the post-acute long-term care setting. Some limitations were identified were other aspects of burnout that can't be measured, such as psychosocial components and outside of the work environment, really that contribute to burnout that obviously can't be measured within the healthcare arena per se. When you look at the theoretical framework that I used, it's a concept developed by Andrews and colleagues called needing permission. And the concept of needing permission is the ability to identify and promote self-care and compassion inwardly, to develop preventative and protective personal care for self, which in turn leads to better care outwardly. And really, it's kind of built on three main framework or pillars: hardwired to be a caregiver. That's a nurse's ability to identify oneself in terms of identifying nursing as a profession versus a calling, and kind of separating those two and allowing balance. And then needing a stable base, and really that focuses around the environment in which they are functioning in, ensuring that there is a safe environment, stable environment, that they feel supported and comfortable working in that environment. And then managing the emotions of caring, meaning at times individuals becoming connected to identifying their self-worth with the care that they're providing, and being able to separate and differentiate and disassociate between the two, and not linking one's self-worth to their ability to care for people. So it's breaking down those barriers, facilitating improvements, allowing safe environments in order to really capture the overarching framework, which is allowing for acknowledgement, acceptance, and a proactive approach to one's personal identity and self and the environment, in order to promote further self-care, self-compassion, and then improve quality of care delivered. And that really kind of links in and ties into the whole project and concept of emotional intelligence, because the main first key of emotional intelligence is self-awareness. And if you don't have self-awareness, it's very difficult to influence and change other aspects of your emotional intelligence and be able to manage those feelings and emotions appropriately. So the method and design of the study: it was a qualitative prospective study done with convenient sampling. A 30-minute education on emotional intelligence was provided to facility A, and there was also a second facility, which is a sister facility, which literally was across the street, that had no intervention done. A pre and post implementation burnout assessment was done of facility A, and there was a 3-month time frame between the pre and implementation of the education, and then the post implementation assessment was done. And then the facility B was gathered at the time of the post assessment as a almost like as a control and a altering data point to compare the two. A independent sample t-test was used to compare the data, and then also there was some descriptive analysis performed regarding the demographic of the population. So sampling, again, convenient sampling done within the healthcare setting, post-acute long-term care, again, facility A and facility B. The inclusion criteria were 18 years of age or older. They provide direct or indirect patient care, have attended the emotional intelligence training course, so that obviously was specific for the intervention group, facility A, and then practice and function within the facility in which the education was performed. Again, that was in relation to facility A. Facility B was not included within that. But again, there was no other outside data collected between these two facilities. And then exclusion criteria: they had not completed the emotional intelligence training in the intervention group and did not provide direct or indirect patient care. So, for example, that would be nursing administration or the RNX or the business office or that specific arena. To continue with the sample, again, there were 3 separate groups that data was gathered on. The pre-intervention group consisted of 33, post-intervention group of 20, and the third group, the no intervention group in facility B, was 17. The demographic data that was collected was age, profession, and years worked. So analysis. So originally, let's start with the descriptive analysis, kind of break down each one of these groups or high points of it. Group 1, again, 33 participants. The majority were in the age of 40 to 49 at 37%. Certified nurses aides were the highest population in this group at 49%, and the largest years worked were 1 to 10. In group 2, 20 participants. Again, the largest group, 40 to 49. CNAs, again, the largest profession, and years worked was a split between 1 and 10 and 20 to 30. In group 3, saw that 17%, again, 40 to 49 was the highest age, CNAs was the highest population, and years worked was 11 to 20. The lowest representation across the board was in the group was age 60, and then certified registered nurse practitioners as the profession, and then individuals with greater than 30 years worked. However, it is one to note, and we will circle back on this when looking in the results. Group 3 had the highest population of 60 plus years and the highest population of 30 plus years worked. Analysis of the Oldenburg burnout inventory score. The scores ranged from 23 to 54, with mean scores in this group of group 1 averaging 38.94%, group 2 37.3%, and then group 3 41.9%. So really the meat and potatoes of the analysis right here, the sample t-tests. So to give a little bit more detail, comparative analysis was used doing parametric testing. According to Pilot and Beck, parametric testing is used when comparing interval scales when certain assumptions are made and there were no identifying outliers and to compare means. So really the minimum sample sizes were met, normality of distribution was significant in the group, and no outliers were identified prior to running the tests. So we ended up running 3 different tests to compare the data and averages. Group 1 versus Group 2 was our main intervention group, saw a mean reduction of 1.6 with a p-value of 0.408. We then compared Group 1, which is the pre-intervention group, to the no intervention group, saw a mean reduction of 3 with a p-value of 0.149. And then Group 2, with the post-intervention group, compared to Group 3, the no intervention group, with a mean reduction of 4.6 and the p-value of 0.04. We also performed a power analysis on each one of these, and Group 1 and Group 2 showed small strength, Group 1 and Group 3 showed a medium strength, and Group 2 and Group 3 showed a medium to high strength. So the results. So unfortunately, the results in the main intervention group failed to show statistical significant reduction in the OLBI score with the implementation of emotional intelligence training. So we didn't see a reduction between the two. However, we did see a statistical significance noted in comparing Group 2 and Group 3 with a p-value of 0.04. In terms of looking at the demographic data, we did note that the highest number of participants were CNAs across the board, ranging 45 to 49% of the participants in each group. So really a bulk of the participants filling out the surveys and taking the education. And there was an interesting correlation between the highest level of OLBI, or burnout group, related in looking at the oldest professionals and the most number of years worked. So looking at Group 3, they had the largest group again, 17% were 60 plus, 11.4% were 30 plus, and 47 in the medium was the CNA population for that group. So limitations to the study. The main intervention group was underpowered. As I referenced before, when comparing group 1 to group 2 being our main intervention, it was underpowered with a strength of 0.238. And then staffing and availability. Really, we had limitations in our location. So originally it was supposed to be given in a more classroom type setting with limited distractions. However, due to staffing availability and time, we had to course correct and the education had to be given at the nurses units. So obviously, if you give an education at a nursing unit, despite what any time you try, there are increased distractions and ability to have lack of attention if you're in that environment. Also, in terms of timing, it was only allotted for 30 minutes, and there was only a 3-month gap between the two. So it calls into question if that really was enough time to adequately provide education and assess true um, intervention or results based on that time period. And then, of course, COVID-19, I actually had to postpone my education or intervention due to the pandemic. And because of that, that actually was the facility's second large outbreak of the pandemic. So obviously that's putting huge stressors on the staff in general, because unfortunately they were hit very hard within the first wave. And when we had that large second wave with Delta, they actually had also several cases in the facility in its entirety was affected by that as well. So they had two very difficult times, which obviously increase stress and add additional elements when evaluating the results. So discussion. So really, I think this is where we can look at, unfortunately, emotional intelligence in this study did not show a reduction in burnout in terms of the post-acute long-term care setting. What we did see is that CNAs were largely affected or are the largest population, which we know that can influence data. And we saw no reduction in burnout. However, this is comparable with data out there already. Aldaz and colleagues noted when they did a study with CNAs in long-term care, found that it wasn't as much as emotional intelligence as it was the ability to recognize emotion and alexithymia that certified nurses aides lacked. So, so really it is consistent with the research that's out there. And then age and years worked are related to burnout, meaning that is also supported through the research as a large influence of burnout. So we confirmed and supported existing data right there. And then barriers and limitations. I really don't feel that this study is generalizable due to the small power analysis, extra associated factors that are related to this, the limitations that were noted in terms of sample size and time and education and staffing. And there was also anecdotal things that came in there, as in, for example, they had a computer downtime and there's increased use of agencies. To put that in I think people lose that. To put that in context for people, the healthcare sector in the hospital system has reported up to a 2% loss or 2% loss of employment or percentage of needing help when compared to the long-term care setting has reported up to a 14 to 15% loss of staff. So really, to put that in perspective, it's astronomical amounts of loss of staff in this setting that really it's hard to quantify and hard to experience that. And the amount of agency, you have hard turnover. So there's a lot of influencing factors that are very specific to this healthcare arena. However, when you do look through the research, I'm happy to say that there were two fairly decent studies done recently throughout the burnout, continuing to show emotional intelligence in contrast to my findings through the burnout, through the pandemic that shows that it is helpful in managing coping, um, reduction in psychological burnout. Really, it continues to show benefit through the literature. Implications to practice. Again, I think it continues to support the need and focus on burnout and ways to look to improve it through healthcare and specifically in the post-acute long-term care setting. Unfortunately, my data doesn't support the mainstream implementation of emotional intelligence into that setting in the burnout prevention. However, I also feel that any bit of education and any tools provided can help. So I can't say that for sure based on this data, and additional research needs to be conducted. I think it highlights the importance of CNAs. Really, they are the backbone to long-term care. So we need to continue to work to help support them, educate them, provide them with emotional training, coping mechanisms, and other modalities to help with burnout. And then also, again, supporting the need to support our aging and more tenured staff within these environments to help support them and to continue them within the workforce as long as they would like in order to prevent that burnout and create a positive environment. In conclusion, burnout continues to be a major concern amongst the post-acute long-term care setting. I know it's a major concern across all healthcare arenas. So I think it highlights the need for continued research and work in that section. And then emotional intelligence, I feel additional research needs to be done and ongoing research needs to be done in the post-acute long-term care. I feel it's a positive and genuine tool to use within the system as we work toward improving staffing ratios and other changes within that environment to help improve burnout. And then improvement to the study design. I think would like to see, I'd love to see a bigger sample size to ensure adequate powering, and then a more constructed educational setting, and then with follow-up. No additional follow-up education was done. It was more on the ground grassroots education and continued talk about it, opposed to a more structured follow-up. So that may be benefit, and then extending the period of post-assessment possibly to a 3-month and then a 6-month to see if there was there. Because there was an anecdotal findings through talking with staff that told me that the education was very helpful and they made some positive changes in their professional life and their personal life based on kind of some of the things that I provided them in tools. So really a reflection of the DMP project as a whole. It was a labor of love, and I'm sure that's been said on many occasions. And it took a lot of patience, time, and it was worth it. It really helped me kind of fall back to some basic research things that I had possibly lost in my career, helped me create frameworks and a different viewpoint of looking at things. And really, I thought it was a huge benefit as a whole, and I always look to push myself professionally and personally and to continue to improve myself and the practice that I provide for patients. So it truly was a great experience. And again, to circle back from the beginning, I very much appreciate everyone's help and support through the project. So with that being said, if you have any questions, please let me know, and thank you very much for your time. Have a great day.